Welcome to this series of lectures in oral medicine, this one entitled Facial Pain, and we'll cover general introduction to temporomandibular disorders and
When we're talking about
so on.
orofacial, I think it's always good to have a differential diagnosis of the type of conditions that can cause chronic pain in the face. And these can be broadly outlined into musculoskeletal, neurovascular, neuropathic, and psychogenic, as suggested by Merrill et al. So, if we summarize that, musculoskeletal could involve muscle problems, joint mechanics, and arthritis conditions of the temporomandibular joint. Neurovascular could include migraine and other primary headaches, tension-type headaches, and autonomic cephalgias. And neurogenic or neuropathic could involve peripheral neuropathy, neuralgias, or central neuropathic pain. Psychogenic, somatization disorders, and other psychotic disorders. Temporomandibular disorder, or TMD, was included in the differential diagnosis of craniofacial pains in 2004 International Classification of Headache Disorders. Firstly, it must be noted that a dentally trained clinician, as dentally trained clinicians, you should initially rule out any dental or oral causes of pain. These could include tooth pain, mucosal, and periodontal disease or sinus pain. But be aware of other common possibilities such as ear problems or eye problems, sinus problems. If we look at the anatomy of the TMJ, from the lateral view, what we have is the condyle, marked A, the mandibular fossa or glenoid fossa, marked B, and the articular eminence, marked C, with the disc in between, and the articular disc has an anterior, intermediate, and posterior components. It's a gangliomo-arthroidal joint, referring to its dual compartment and structure and function. It has a hanging or hinging as well as a gliding movement. It rotates forward on opening and then rotates and then translates forward. The articular disc, only other joint being the sternoclavicular joint, is composed of dense fibrous connective tissue devoid of nerves and blood vessels. So there's no neural component or vascular component to the disc. The inferior disc compartment allows pure rotation and accounts for about the first 20 millimeters of opening, or 2 centimeters. Superior compartment is involved with further opening, which involves translation. There are 6 main components of the TMJ: the mandibular condyles, articular surface of the temporal bone, capsule, articular disc, fibrous extension of the capsule separated in the 2 bones of the joint, ligament, 3 ligaments: temporomandibular, stylomandibular, and sphenomandibular ligaments, and the lateral pterygoid muscle. The gross skeletal anatomy of the mandibular condyle into the skull base, shown in this skull photograph, and this is a cadaver dissection showing the disc in the middle with the condyle and the mandibular, the glenoid fossa in cross section. Again, this is a schematic of the same, which showing the upper head lateral pterygoid muscle attaching to that, and the lower head lateral pterygoid attaching below, posterior band, intermediate zone, and anterior band. And from frontal view, it looks like a schoolboy with a cap on, which is the articular disc. And the lateral pole is shown on the the lateral aspect, and the medial pole on the medial aspect. Again, with the disc you have an upper or superior joint cavity and an inferior joint cavity. And when we're talking about arthrocenthesis, it is joint cavity that the fluid is injected and taken out again to wash out, the so-called washing out of the joint. So it almost is like a suspension bridge with the temporomandibular capsule or capsular ligament holding everything in place, but like a suspension bridge that you see where cars driving over, where this is the part that holds the working surface in together. So the movement of the TMJ is like a suggested schoolboy cap as the joint or the condyle moves forward and rotates and translates. The disc doesn't have, or during rotation there's no movement of the disc, but continued rotation of the condyle relative to the disc and forward translation of the condyle, and then maximum opening. You can see stretching of the posterior portion of the disc. So in video footage of this showing the cadaver on the left and the clinical patient on the right, showing how the disc and the condyle move as it translates forward on opening. And again you can see this movement. In a normal action, but sometimes if that disc is caught behind or in front of the condyle, then you have restriction of movement as well. So sensory innervation of the temporomandibular joint is derived from the auriculotemporal and mesenteric branches of the mandibular 5. Arterial supply is from the external carotid, and some contribution from deep auricular and anterior tympanic, ascending pharyngeal and maxillary arteries. So the procedure is with regard to diagnosis of chronic pain, is no different to any other clinical examination that you do for all patients. The most important thing is to talk about the presenting complaint, because that gives us an indication of why the patient, or what's worrying the patient and why the patient is there. We may find other things that are a problem, but we need to make sure that we help the patient alleviate their main presenting complaint. Then history and symptoms are very important, especially important in chronic pain, because it will give you an idea of how to differentiate between your differential diagnoses. Extraorally, you might palpate the nodes and salivary glands, look for presence of tenderness of temporalis and masseter muscles, joint sounds as well as tenderness on opening and closing, mandibular movements, and cranial nerve function. Intraorally, you look for the condition of the teeth, the periodontium and mucosa, saliva content and consistency, signs of bruxism, muscle palpation, especially of the masseter and pterygoid muscles. Special tests that you may carry out for orofacial pain, radiographs, orthopantomogram, gives you a good review of the upper and lower jaws for any other possibility of pathology in the sinuses and or in the bony structures. CT scan and an MRI, especially MRI is useful for looking at the joint compartment, especially the disc, and to look for any perforations. Blood tests also to look at the general condition of the patient's health. Transcranial and OPG radiographs are mandatory. MRI can be 27 to 30% inaccurate due to disc fibers being orientated longitudinally as well as circumferentially, even though it's suggested to be the gold standard of diagnosing joint problems. So a patient may present with uni or bilateral facial pain, ear pain, tinnitus, fullness in the ear, headaches, which could be frontal, temporal or occipital, eye pain described often as retroorbital or periorbital pain, pain on upon chewing or yawning or eating chewy foods, inability to open the mouth wide. Extraorally, you might see signs for general health, nerve function, or one or all of tenderness of temporalis muscles, which could also be an indication of temporal arteritis, masseter muscles, tenderness of the TMJs, mouth opening less than 3 centimeters with or without pain, pain on lateral mandibular movements, palpate nodes and salivary glands for any swelling or tenderness. Signs intraorally would exclude any dental or mucosal pathology. Look for tenderness of masseter and lateral pterygoid to palpation, and then you carry out your radiology, blood test, and then arrive at a diagnosis. Temporomandibular imaging, MRI, can be useful for picking up other pathologies, such as here you've got a parotid hemangioma in this arrowed area. You take an OPG radiograph, make sure that you train yourself to look at radiographs systematically, starting from one end, working your way always in a similar manner, looking at the TM joints, the mandible, the teeth and the surrounding bone to the other TMJ, and then on the maxilla coming back through. Even those sinuses, maxillary sinuses, aren't within our scope of management, you can still get used to looking at the normal, so that if there's something abnormal you can refer the patient. TMJ views can also give a close-up review of the joint, condyle, and any possibility of any arthritic changes which may show up as notches or any radiolucencies associated with the joint. Management generally would involve conservative advice and self-help exercises, occlusal splint therapy, physiotherapy or massage therapy, medication such as muscle relaxants and pain relief, arthrocentesis, which is washing out the joint as explained earlier, and rarely surgery, especially if there's arthritic damage and or pathology, in which case a joint replacement may be required. And counselling is also required, because these patients with chronic pain have ongoing pain for months, maybe years, and even though the management may be helping, often the management involves gradual improvement of pain. So if we look at the biomechanics of jaw function, in utero, mouth movements lead to the development of TMJ through cavitation. And so prevention of mouth opening means no cavitation, implying no joint space or ankylosis. Middle ear and TMJ are intricately connected, and this is why you may get ear symptoms in temporomandibular disorders. So if we look at limb reception compared to jaw reception, limb reception involves mechanoreceptors, muscle spindle receptors and cutaneous mechanoreceptors, whereas with the jaw you have the muscle receptors, the Golgi tendon organs, TMJ capsule, as well as a periodontal ligament involved in the function. So biomechanics of jaw function, if you look at sensory organs, you involve the brain descending control, pattern generating network, reflex network, motor neuron leading to movement. So we talked about musculoskeletal. If we now turn our attention to neuropathic pain, definition of neuropathic pain is pain initiated by a primary or lesion or dysfunction of the nervous system. In primary there's no recognised pathological process, whereas in secondary there is a recognised pathological process, for example post-herpetic neuralgia. Orofacial region, neuropathic orofacial pain, NOP, is continuous burning quality, example post-herpetic neuralgia, or paroxysmal, such as trigeminal neuralgia, which causes short electrical or sharp pain. Peripheral sensitization involves when the neurons are becoming unusually sensitive and develop spontaneous pathological activity. So what happens is that if you are constantly stimulating that receptor, then often it will start to require less stimuli to create excitability, and this is called peripheral sensitization. And those stimuli causing constant stimulation of central receptors will lead to central sensitization in a similar manner. The mechanisms of pain, if we look at A delta fibers, which are nociceptors and which are activated by mechanical and thermal stimuli, they're the smallest of the myelinated fibers, 2 to 5 micrometers in diameter, with a fast conduction, whereas the C nociceptors are polymodal, mechanical, thermal and chemical reception. C fibers are unmyelinated and they are slow conduction. So nociceptors are stimulated when the pain threshold is reached, and an impulse is then propagated along the fibre to the dorsal horn of the spinal cord or the medulla. And the stimulation can be through physical, mechanical injury, or noxious heat or radiation, or byproducts of the tissue damage, such as chemicals released from damaged cells such as bradykinin, potassium, serotonin, histamine, cytokines, and etc., and mediators released from afferent nociceptors including substance P, which is involved with peripheral neuropathy, calcitonin gene-related peptide, CGRP, and neurokines. After a brief period of noxious stimulation, and you get an inflammatory soup which is produced, which leads to increased sensitivity and a lowered threshold of the receptors. So pain can then, therefore, in chronic pain can be maintained at a much easier level. This schematic shows a receptor at the synapses where chemicals move from one side, swim across to the other side to other receptors, and therefore the impulse comes in and then goes propagated through the synapse onto the other fibre. So with regard to classification, International Headache Society only has deafferentation as an alternative, but not all trigeminal neuralgias and post-traumatic neuropathies are due to deafferentation. So there are limitations with the classification used by different societies. So the International Association for Orofacial Pain classifies neuropathies of the trigeminal system as secondary trigeminal neuralgia from trauma. American Association of Orofacial Pain lists deafferentation, post-traumatic and post-herpetic, as well as post-surgical neuralgia, but does not define the criteria. Neuropathic pain may affect 1 to 1.5% of the population, although it has been reported as high as 8 to 11. Further study in the UK on the epidemiology of 4 neuropathic conditions: post-herpetic neuralgia, trigeminal neuralgia, phantom limb pain, and painful diabetic neuropathy, found an overall prevalence of 83.8 per 100,000 people. So when we talk about management, treatment, the NNT, or the number needed to treat, is the number of patients in a random controlled trial required to be treated in order to obtain one patient that gets cured. Absolute risk reduction is calculated by subtracting placebo response from the observed drug response. So for example, if the drug response equals 50 and placebo is 20, then the ARR is 30%, and the number needed to treat is 3.3, which implies that every third patient gets relief. The number needed to harm represents the number of patients in a clinical trial who needs to be treated in order to obtain one patient with minor or major side effects studied, and is called calculated as NNT. High NNH indicates favourable therapy. So with trigeminal neuralgia, it's an excruciating, short-lasting, less than 2 minutes unilateral facial pain that may be spontaneous or triggered by gentle or innocuous stimuli, separated by pain-free intervals of varying duration. So once that initial pain is initiated, a second one cannot be initiated straight away. So two subsets, classical and symptomatic. Classical, previously called idiopathic or primary, may be related to neurovascular compression. Symptomatic, previously secondary or atypical trigeminal neuralgia, occurs in up to 30% of cases and presents with some but not all diagnostic criteria. More refractory to treatment, however. So the pathophysiology may be that in these cases you get compression of the trigeminal root at or near the dress zone by blood vessels, and is considered a major causative or contributing factor. Imaging often is positive in 78% of the cases. Trigeminal neuralgia due to demyelination caused by the compression leads to increased A-beta neurons, which then produce sub-threshold oscillations that generate ectopic discharges, which may then cause transient depolarization in neighboring passive C fibers. Neuropathic pain can be very difficult to treat, with only some 40 to 60% of patients that achieve partial relief. And based on current evidence, trigeminal neuralgia, carbamazepine was the drug of choice. However, carbamazepine is not without its significant side effects. Other medications such as oxcarbazepine or lamotrigine may be used. More recently, gabapentin has also been shown to be effective. Antidepressants such as tricyclic antidepressants, anticonvulsants such as pregabalin, Lyrica, and gabapentin, lidocaine, and other newer medications are used to block the chemical synapse or chemicals involved with synapse, and therefore to block the pain impulse from propagating. Antidepressants, activation of descending noradrenaline and serotonergic pathways to the spinal cord limit pain signals ascending to the brain. So compounds such as duloxetine, venlafaxine, and that block both serotonin reuptake and norepinephrine reuptake do improve neuropathic pain. Tricyclic antidepressants may also work on sodium channels in peripheral nerves. This slide shows some information about the anticonvulsants, lamotrigine. Topical agents such as lidocaine can provide analgesic relief. Topical capsaicin provides substance P depletion. I mentioned substance P before, which is involved with peripheral neuropathy, so we can use topical capsaicin on the area of peripheral pain to get rid of the substance P, which over a long period of time will be depleted, and then you get improvement in pain. Botox, botulinum toxin type A, local infiltration injections can provide pain relief for up to 14 weeks. In some neuropathic pain syndromes, crosstalk can occur between descending sympathetic nerves and ascending sensory nerves. Increases in sympathetic nervous system activity result in an increase of pain. This is called sympathetically mediated pain. Lesioning operations on sympathetic branch of the autonomic nervous system are sometimes carried out. If we now turn our attention to neurovascular pain, types of neurovascular pain include migraine, cluster headache, paroxysmal hemicrania, and other variants such as ice-pick headache or hemicrania continua. With regard to migraine, it affects about 16% of the population, more common in females. Genetic factors may occur and usually develop in the first 3 decades. An aura may be present, This prodrome may be hours or days before migraine. Mental slowness, depression, irritability, restlessness, and euphoria may occur, lasting 20 to 60 minutes. A visual aura, such as zigzag lines or flashing coloured lights across a visual field, or blind spot scotoma. Sensory symptoms such as paresthesia of the arms, elbows, and hands and neck may occur. Severe throbbing, debilitating pain with phono or photophobia may occur. Mayhem, nasal stuffiness, or nausea and vomiting may also be prevalent. Prodrome tiredness, we will seek tiredness may occur, and patients will seek a dark room for sleeping. Pathophysiology, does it involve the trigeminal vascular system, a neural invasion of the intracranial system stimulated by neural and neurotransmitters, which are chemical activators, leading to a cascade of effects that will lead on to pain. Trigger foods such as hot dogs, MSG, red wine, and other alcohol is implicated. Management involves education of the patient, because again this is a chronic pain condition. Trigger avoidance, non-pharmacologic, such as maintaining a routine and relaxation. Pharmacologic, abortive things such as non-steroidal anti-inflammatory drugs, ergotamine. Preventative calcium channel blockers, which block 5-hydroxytryptamine and inhibit vascular muscle contraction. Cardicem. Serotonin antagonists such as methotrexate blocks development of neurogenic inflammation. Tricyclic antidepressants, which increases the availability of synaptic serotonin and noradrenaline by inhibiting uptake. Example of tricyclic would be amitriptyline. Cluster headache is less common than migraine, also called migrainous neuralgia or Reader's syndrome. Affects men more than women in the 20 to 50 age group. No significant hereditary factor, but develops quickly and peaks in 22 to 15 minutes. Intense, excruciating, deep pain, may get paroxysms of stabbing, ice pick like periorbitally. Unilateral pain, and is accompanied by ipsilateral lacrimation as well as a nasal drainage, and lasts for about 30 minutes to 2 hours. Pain commonly occurs at the same time, for example 2 a.m. Cluster headache diagnosis mainly from the history, and management involves patient education and avoid trigger factors. Maintain good sleep, biologic clock. Non-pharmacologic, compression of superficial temporal artery. Pharmacologic, oxygen 100% given, as well as ergotamine. In comparison to this, paroxysmal hemicrania is very similar clinical presentation, but it's more common in women, more frequent attacks, 10.8 mean in 48 hours. Shorter duration, mean of 13.3 minutes compared with 49 minutes for cluster headaches, and is the paroxysmal hemicrania is responsive to indomethacin management. So neuromodulation is a field of science, medicine and bioengineering that encompasses both implantable and non-implantable techniques, which can be electrical and chemical for treatment purposes. Spinal cord stimulators use electrode placed at adjacent to but outside the spinal cord. The overall complication rate is 1/3, most commonly due to lead migration or breakage. Lack of pain relief sometimes prompts device removal. Stimulation of the primary motor cortex through electrodes placed within the skull but outside the thick meningeal membrane dura has been used to treat pain as well. The level of stimulation is below that for motor stimulation. As compared with spinal stimulation, which requires a noticeable tingling, paresthesia. For benefit, the only palpable effect is pain relief. If we want to gain an understanding of psychology of pain, we need to look at the different models. Axis 1 being the medical model, which is what we see in the physical world. Axis 2 is a psychiatric model. And with pain, especially long-term pain, you get a combination of Axis 1 and Axis 2, the biopsychosocial model. Psychological influence on pain perception include cultural factors, past experience of pain, whether they've felt pain before or how badly, that will set the precedence for future pain experience. Mood, fear, anger, depression, gender and sex. It's indicated that females feel pain more, and this could be due to the fact that females have less descending inhibitory fibres physiologically, and the context in which the pain occurs and the patient's belief about pain. Fear generates anxiety, and the more the patient focuses on it, the worse it appears to become. Therefore, as pain becomes chronic, then the anxiety increases. Therefore, you need to treat the anxiety as well as the pain. So if we look at a past model, you talk about the biological and behavioural factors. Biological factors involve genetics, autonomic balance, allostatic load, fitness level and nutritional status. All of those things can affect the biological aspect of pain. Behavioural factors such as principles of learning, interpersonal processes, relaxation, skills and cognitive regulation will affect the behavioural factors associated with pain. So in the past, we've come up with a biopsychosocial model which involves biological, psychological and social events, and assessment for biobehavioural will involve a psychological interview, diagnostic questionnaire, and treatment involves relaxation training and cognitive restructuring. Whereas the biomedical, the assessment involves physical exam, laboratory tests and imaging. Treatment involves medication, injection, splint, surgery, and physical modalities, ice, heat, and so on. There is strong evidence base for cognitive operant behaviour therapy, relaxation training and graded exercises for chronic back pain, but this is minimal for chronic facial pain. Moderate evidence for hypnosis in both back and facial pain, strong evidence in both for EMG biofeedback. So we must think in terms of simultaneous treatment, not serial treatment. So all of these pain conditions, all the areas need to be managed at the same time. So if we look at the latest research, the Opera study, orofacial pain perspective evaluation and risk assessment of TMD. If we look at painful TMD, which can be persistent, transient or subclinical, it has input into it from high psychological stress that could involve mood, anxiety, depression, stress and somatization, and high state of pain amplification, which can be modified by neuroendocrine function, autonomic function, impaired pain regulation, and pro-inflammatory state, and these have an interaction between themselves. Environmental contributors such as physical environment, trauma and infection may initiate. Social environment such as life stresses, which play a part in the psychological stress, culture, health beliefs and demographics, but more importantly, the genetic effect of these factors by different phenotypes that are available, especially the COMP gene, which is suggested to be the pain gene that they've more recently done studies on, appears to, in different phenotypes, make a person more susceptible to feeling pain and becoming a chronic pain sufferer. Thank you.